Okay, so we talked about the pituitary gland, the posterior pituitary gland, the anterior pituitary gland, and now we're going to talk about the adrenal glands. All right, so the adrenal glands, you have two parts of the adrenal glands. You have the adrenal medulla and you have the adrenal cortex. All right, one thing that I want to talk to you about the adrenal medulla is that there's a certain kind of tumor. It's a rare tumor, but it usually happens in the adrenal medulla gland, and that rare tumor's name is pheochromocytoma. 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 And I don't understand exactly why, because I've never seen this in my personal nursing practice, but NCLEX questions love to focus on pheochromocytomas. ATI questions have at least one or two questions that are on this pheochromocytoma, so I just want to go over it with you. The pheochromocytoma is an uncommon tumor that arises from the adrenal medulla, okay? And signs and symptoms of this are going to be, basically what happens with this pheochromocytoma is that it causes an exaggerated response of the fight or flight. Okay, so fight or flight, that's your norepinephrine. Your epinephrine, that's where everything is going to speed up. Your blood pressure, your heart rate, your palpitations, okay? So if you think about that, that's what your fight or flight normally is. Then you think about what the pheochromocytoma, that causes exaggerated episodes of fight or flight. That means that it can last for a long period of time, or it can happen in episodes, but at that time when you have exaggerated symptoms, that means that you're going to have hypertension, tachycardia, palpitations, tremors, diaphoresis, feeling of apprehension, and severe pounding headaches. Those are all signs and symptoms of a pheochromocytoma. So then, how are they going to test for that? They're actually going to do a 24-hour urine test that's going to test for metanephrines, which means that it's for all the epinephrine and norepinephrine, metanephrines, and something called vanillyl mandelic acid, or VMA. Okay? When those tests are positive, then they go ahead and do a CT scan or MRI that's going to show where exactly the tumor is. And at that point, what you're going to need to prepare for is to have that tumor removed, okay? So, they're going to give some beta blocking medications, and that may help to slow down those fight or flight symptoms, but ultimately they're going to go in and they're going to remove that tumor. But here's the deal. When they go in and they remove that tumor, they are going to remove the adrenal medulla. Okay, so that means that now this person is going to be at risk for hypotension, all right? High and hypoglycemia. Okay, so the biggest thing you need to do after somebody has surgery to remove a pheochromocytoma is that you need to monitor vital signs very closely, and you need to monitor blood glucose. it's more than normal, post-surgery monitor vital signs. This is crucial because you are removing the part of the kidney, the adrenal medulla, that actually, well, it's not the kidney, but it sits on top of the kidney. You're removing that part of the adrenal gland that's responsible for regulating blood pressure. So you need to very carefully monitor the vital signs. All right, that takes us to the adrenal cortex. Now, the adrenal cortex is responsible for regulating three things: sugar, salt, sex. Sugar, salt, sex. It regulates these things by regulating glucocorticoids. Okay, so now we're talking about steroids because this is a corticoid. Okay, so glucocorticoid regulates the sugar. Mineral corticoids regulate the salt. All right, and then testosterone regulates the sex. Sugar, salt, sex. That's what the adrenal cortex normally regulates. When it is in a balanced state, sugar, salt, and sex are all balanced and they're working properly. Now, I'm going to try and give you ways to remember this. There's two things that happen. You have a hypo, which is called Addison's disease. And this is how I remember this. When it's hypo Addison's, you have to add to it to bring it up to a balanced state. So you have Addison's disease because you're adding something to it to bring it up to a normal state. When you have too much stimulation and too much overproduction, then you have a hyper state, and that state is called Cushing's disease. And I remember that it's too much because there's a cushion of it. Cushion because there's too much and it's Cushing's disease. Addison because it's too little and I have to add to it to bring it up. So I hope that kind of like brings it into your mind so you're like, oh yeah, I remember that. All right, so now let's talk about hypo, or let's talk about adrenal cortical insufficiency known as Addison's disease. All right? Addison's disease. Addison's disease is an insufficient production of hormones of the adrenal cortex. What are those hormones we talked about? Those are glucocorticoids, mineral corticoids, and testosterone. Okay? Because again, the adrenal cortex is responsible for regulating three things: sugar, salt, sex. All right? So you have, let's just kind of work this through. You have the pituitary gland that releases adrenal corticotropic hormone, or ACTH, and the ACTH then stimulates the adrenal cortex to produce mineral corticoid, glucocorticoids, and testosterone. All right? Say it again. The pituitary gland stimulates the production of ACTH, adrenal cortico-stimulating hormone, okay? And the ACTH then stimulates the adrenal cortex to produce mineral corticoids, glucocorticoids, and testosterone. And those three things regulate sugar, salt, sex. All right. So, when we don't have enough glucocorticoid, mineral corticoid, or testosterone, then what do you think the signs and symptoms are going to be? the biggest sign and symptom of Addison's disease is going to be hypotension, because one of the steroids that helps to that is stimulated by ACTH is also aldosterone. And I know that I'm asking you to reach way back in your memory, but if you remember, aldosterone helps to regulate the salt and water retention. Okay, so when we don't have enough aldosterone or mineralocorticoid steroid, then we don't have enough sodium retention, and we don't have enough water retention, and so our blood pressure is going to be low. All right? So sodium and water are lost, hypotension happens, and tachycardia is a result. All right? When we don't have enough glucocorticoid steroids, what's going to happen? Our sugar is going to plummet. All right? So we're going to have hypoglycemia. All right, so now you're following me, hopefully. You see that we have hyponatremia, hypoglycemia, all right? And that is really what causes the fatigue and the weight loss and the confusion that is associated with Addison's disease. One of the other things that you may not know is that Addison's disease causes a bronzing or a tan appearance to the skin. And just of note, just because JFK, John F. Kennedy, our president, had Addison's disease. And everybody used to think he was so healthy and he had this great tan. Well, that great tan was actually this bronzing or this tanning that happens with Addison's disease. And Bobby Kennedy, his brother, and the Secretary of State actually have records of where he had to give him steroid shots, glucocorticoid shots, and aldosterone shots, because he had times where he went into what is known as an Addisonian crisis. Now, an Addisonian crisis is where you take all those signs and symptoms, hypotension, hypoglycemia, and you take those and you spiral them out of control. So a hypotension state is now, instead of maybe being 90/50, now it's toileting the drain, it's circling the drain, and it's down to like 80/40 or 50/30. So it's severely hypotensive, okay? And then your blood sugar plummets. And normally in an Addisonian state, it'll decrease and it'll be low. But in a crisis, instead of being low at maybe 70, now it's low at 40. Okay? So that is what an Addisonian crisis is. And the way to treat an Addisonian crisis is to administer IV fluids, because you're wanting to build up that volume so that you're building up the blood pressure. And you're wanting to obviously add glucose to it, so you're going to inject them with glucose, D5 or actually dextrose, straight into their blood to bring up their blood sugar right away. And that is what Bobby Kennedy had to do, because surprise, surprise, one of the biggest ways to put somebody in Addisonian disease or Addison's disease into an Addisonian crisis is through a stress event. Well, being the President of the United States, you can imagine the kinds of stress events that happened. So it was frequently that Bobby Kennedy had to do a whole series of glucocorticoid shots, steroid shots, IV infusions on President Kennedy to keep him from going into a Addisonian crisis. So, again, when there's low production a hypo amount of mineralocorticoid steroid, glucocorticoid steroid, or testosterone, you get a disease called Addison's disease. And it's called Addison's disease because you have to add to it to bring it back up to normal balance. All right. The opposite then of that is called Cushing's disease, and that happens when there's too much mineralocorticoid steroid, too much glucocorticoid steroid, and too much testosterone. All right. This disease is called Cushing's disease, okay? Because there's a cushion or an overabundance of steroid production. Okay, so you may have heard that people who take prednisone or prednisolone for a long period of time, they develop weight gain or they develop a moon face, which means that their face becomes really puffy and round. Now, I know I have a round face, but that's what a moon face would look like. Okay? So, that's a moon face. But I want you to get this picture in your mind, okay? People with Cushing's disease have a big, fat body and little tiny legs, little tiny arms sticking out. So, right now, as you're listening to this, draw a big, fat circle with little tiny sticks growing out of their side for their arms and little tiny legs growing out underneath this big fat circle, okay? Because truncal obesity is one of the signs of it, okay? Then what I want you to picture is that on that trunk, I want you to picture swinging or pendulous breasts. Think about, do your boobs hang low? Do they wobble to and fro? Okay, that is the pendulous breast syndrome, where the boobs are really just hanging low. The girls are out and unsupported, and they're hanging low. Pendulous breast. Again, you have this big circle and these big swinging boobs on this big trunk, okay? And the little tiny arms and the little tiny legs growing out. Okay, so I want you to try and envision this as we're talking about it, because it will help you to understand the signs and symptoms of Cushing's disease. Now, on that big fat tummy, you have little purple striae because they get stretch marks all around on their tummy. So you have this big fat tummy, purple striae or purple stretch marks, little tiny legs growing out, little tiny arms, and you have pendulous breasts swinging back and forth, all on this trunk. Now, we're moving from the trunk, and on the top of this big fat body, you have a little hump called a buffalo hump or a dowager's hump. That is also caused by an overproduction of glucocorticoid steroid, mineralocorticoid steroid, and testosterone. Okay, is that little buffalo hump. So now you have this big body and this little hump over onto the side of it, the buffalo hump. Okay, and then to put a face on this body, I want you to draw the face in the shape of a moon, okay? Because people with Cushing's disease often get a moon face. And now remember that in this case, moon means fat and swollen. But for sake of the cartoon and sake of the picture in your head, I want you to draw a half, not even a half moon, but a sickle of the moon, okay? A quarter of the moon. And I want you to put eyes and a mouth on that moon. And then I want you to draw a beard on the moon, because people with Cushing's disease have hirsutism, where they have a lot of facial hair, which for a woman obviously isn't the prettiest thing ever. And so they have thick, coarse hair on their face, on their chin, on their cheeks, sometimes even on their chest. Women will have hairy chests like a man, and it's because of this hirsutism, or this overproduction of glucocorticoid steroid, mineralocorticoid steroid, or testosterone. All right. So that kind of gives you the picture of what this person looks like. And then if you look on page 908 in your book, it actually shows you what I'm talking about. But some of the signs and symptoms then, what we would talk about is that their blood sugar is going to be very high. So just like in Addison's disease, their blood sugar was low. In Cushing's disease, their blood sugar is going to be very high. Okay? They're also going to be prone to what we typically know as roid rage, where they get very angry and have fits of emotional outbreak, okay? That's the testosterone going on. That's that increase of testosterone that's associated with people who inject steroids. That's what it is, all right? So it increases the blood glucose. It increases the sodium, and it causes potassium to be lost. So you have hyperglycemia, hypernatremia, and hypocalcemia, meaning that the potassium is lost, the salt goes up, the sugar goes up, and weight gain and all of those other signs and symptoms that I just painted for you. That is called Cushing's disease. Typically, as you stop taking those steroids, or you remove whatever is causing the overproduction of those steroids, as you do that, then some of those signs and symptoms will resolve, and you won't have the moon face anymore. You may be able to start to lose some of that weight. Your bones are not as fragile as they were before. So the question then is, what are they going to do? So remember, in Addison's disease, what did we have to do to bring the Addison's disease back, or the Addisons back up to a balance again? We had to add glucose to it. We had to add sodium to it. We had to add that to bring it back up. Cushing's, there's a cushion of it, so we're going to have to take away from it. And in this case, we're going to do an adrenalectomy. We're going to remove that cushion, and we're going to actually remove the tumor that is causing the overproduction of those three things: mineral corticosteroids, glucocorticosteroids, and testosterone. Whew. Okay, so you may have to do an adrenalectomy, or you may have to do a hypophysectomy. So hypophysectomy is removal of the pituitary gland. If the problem is that the pituitary gland is causing too much stimulation of the ACTH, or you may have to remove the adrenal gland if there's a tumor that's causing too much of the three chemicals: glucocorticoid, steroid, mineral corticosteroid, or testosterone. So, I believe then that this covers chapter 39 in your book. And the next one that is in your book is all about diabetes type 1 and diabetes type 2. And then it talks about, let me see here, it talks about diabetes 1, diabetes 2, and then it talks a lot about carb counting and the onset, peak, and duration of insulins. And it talks about transplants. So what I want to do real quick, and when I say real quick, I really do mean real quick. I know you guys don't believe me that I do know how to say things quickly, because I am long-winded, but here I go. Alright. Type 1 diabetes used to be known as juvenile diabetes mellitus, but basically what is happening is that the pancreas does not produce any insulin on its own. That's type 1 diabetes. The pancreas does not produce any insulin on its own. Okay? And it's usually it's believed to be an autoimmune response. Okay? So people with type 1 diabetes usually have antibodies in their cell that fight against the islet cells that produce the insulin. Boom, that's it. It's pretty straightforward. It's pretty much simple like that. Okay? The patient with type 1 diabetes is most often young, they're most often thin, and they're the ones that are most often going to develop ketoacidosis when their blood glucose is high. Okay? Ketoacidosis. Ketones are a byproduct of protein, and acidosis is too much acid in your blood. So the ketones are producing too much acid, and now this person is acidotic. Okay, ketoacidosis. And that's what causes the fruity breath that people associate when they're in a DKA, diabetic ketoacidosis. Fruity breath is caused by the ketoacidosis. All right, the second type of diabetes is called non-insulin dependent diabetes mellitus. Now, non-insulin dependent diabetes mellitus can, over time, turn into type 1 diabetes, because at a certain point of time, their body, a type 2 insulin dependent diabetic, their body may stop producing insulin. And at that time, then, they will still be considered type 2 diabetic, because that's what it started off as, but in effect, they have the same problem as a type 1 diabetic does, because their body will eventually stop producing stop producing insulin. Sorry guys, it's getting late, and I worked today and I have to work tomorrow, so at this point I'm getting tired, but I want to make sure that you guys get this. Alright, so another type of diabetes is called gestational diabetes, and that happens to pregnant women, and that usually resolves once the baby is born. But what that does do is it makes the person at risk of developing diabetes type 2 later on. So, classic signs of diabetes. Polydipsia, the three polys: polydipsia, polyuria, and polyphagia. And let me explain to you what's happening here. Okay, so you have your blood over here, and you have in your blood, your blood is full of glucose, and you have your cells that are over here, but the glucose cannot get into your cells, and your cells are lacking glucose. They need glucose to eat, and your cells are starving. So they send signals to your brain that says, I'm hungry, feed me. And so you have polyphagia. You're constantly eating, you're constantly hungry because your cells are starving. But what happens is you're eating as fast as you can, and your body's converting all of that food into glucose, but your glucose is staying in your blood and is not coming into the cell. That's because in order for the glucose to go from the blood to the cell, it has to have a carrier. So what I do is I liken the insulin as an 18-wheeler. The insulin has to go to the blood. It goes to the blood. It picks up the glucose, because remember, the glucose cannot get into the cell by itself. It has to be carried there. The insulin is actually what goes to the blood, and it's the 18-wheeler. It stacks up glucose from the blood, and it carries it into the cell, and it opens the garage door, so to speak, of the cell, and it goes into the cell, and it carries and it deposits all the glucose there. Okay, and now the cell is no longer hungry. So when you have diabetes mellitus, your cells are starving, so you're constantly hungry, polyphagia. Then, because your cells are hungry, and then what happens is, so you have all this thick glucose here, and your body's trying to get rid of this glucose, so you start to urinate to try and thin out your blood, to try and dilute this blood. It doesn't work, so you're starting to pee a lot. Because you start to pee a lot, you're thirsty a lot. So that's how you get polydipsia, polyuria, and polyphagia. And that's kind of how that works with the whole diabetes things, okay? So remember, if you remember nothing else, that glucose is going to stay in your blood unless the insulin acts as an 18-wheeler and transports that glucose from your blood into the cell and deposits it into the cell. All right. That's basically what's going on with the basics of diabetes. Now, the rest of the chapter really deals with the specifics of testing for diabetes, which, I hope you guys realize that you really have to know that in order to get a true diagnosis of diabetes, you have to have multiple fasting blood glucose tests that are greater than, and it depends on what facility you work at. At Baycare, it's 70 to 110. Anything above 110 is considered above normal. Some places it's 80 to 120, 70 to 110, but it's around that range, okay, which is considered normal for fasting. All right, and then you have oral glucose tolerance test, OGTT is what it's referred to, and it measures blood glucose at intervals after the patient drinks this nasty carbonated, concentrated carbohydrate drink. It tastes like orange drink, but super sugary sweet. And a result between 140 and 199 at 2 hours, it leads to a diagnosis of impaired glucose tolerance. All right, and then the other big thing that you need to know about is your HbA1c. That's the amount of glycosylated hemoglobin. And we know that glycosylated hemoglobin lasts for about 3 months. So the level of HbA1c dictates the amount of blood, amount of glucose that's been in your blood over the last 3 months period of time. So usually the doctors like to see that below 6% or below a 6. Anything below a 6 of a HbA1c indicates good glucose control. Anything above a 6.5% indicates poorly controlled glucose. And that tends to be a better indicator for a doctor about blood glucose levels than a snapshot in time. He still wants to take a picture of the blood glucose today to see how it looks like today. But if you look at this and you focus just on my eyes, you're going to say, wow, she's an eye. But when you take the whole picture, then you can see more than she's an eye, she's a whole face. That's kind of how fasting blood sugar is, just eyes, and then the HbA1c is the whole face, because it takes it from a further picture and it brings it back, and you see the whole full picture for 3 months of how this person is regulating their glucose. Now, this isn't a hard and fast rule, but this is a general rule. And basically what they say is this, is that if a person's HbA1c is a 7, then on average, their fasting glucose has been around 170. If it's an 8, on average, their fasting glucose has been 205. If it's a 9, 240. If it's a 10, 275. If it's an 11, 310. And if it's a 12, 345. And people who suffer kidney disease or kidney damage or retinopathy or neuropathy usually have HGBs that hang out somewhere in the 8 to 12 range. And obviously the higher the HbA1c, the more in-depth the damage is, or the quicker the damage happens. So I hope that's making sense to you all. Something else that I wanted to bring up, remember how just a minute ago we were talking about type 2 diabetes and how, well, not just with type 2 diabetes, but with diabetes in general, you have the glucose that's in the blood, and you have to have the insulin, which is the 18-wheeler that comes and picks up the glucose. Well, here's something interesting to note. Why is it that you think that people who have, who are overweight, who are fat, or who have higher fat content, have a harder time regulating their glucose? Why is that? Why is it that as soon as people drop their fat content, lose weight, then they have better control over their diabetes? What is that link? Well, here's the link. The insulin has an affinity or has a liking for fat cells before it has a liking for glucose. So basically, when the 18-wheeler goes into the blood, it's going to start to pick up the fat cells first, and it's going to load up the 18-wheeler with fat cells first, and then with glucose. So you're going to have more fat cells in the 18-wheeler and just a little bit of glucose, and it's going to bring those fat cells and a little bit of glucose into the cell. So the cell is going to be filled with fat and just a little bit of glucose, leaving a high amount of glucose still in the blood. That's why when people will lose weight, lose the fat, their blood sugar seems to come down. It's because the insulin, there's no longer the fat cells that are competing for space in the insulin truck to bring it into the cells. So, I think that that's kind of self-explanatory. Just make sure that you understand that when people exercise, it brings down their blood sugar. So they really have to think about when they're giving themselves insulin, and they really have to know the peaks and the onsets and the duration of the different insulins. And you need to look on in your book on page 923 at the chart that they have there. Make sure that you're familiar with the onset, peaks, and duration, because they can ask you questions on the test basically about, somebody who is giving themselves fast-acting or very short-acting insulin like Lispro or Aspart, that the onset is in 15 to 20 minutes and the peak is 30 to 90 minutes. They probably don't want to give themselves that insulin and then go and exercise within that same amount of time, because that insulin is going to kick in and it's going to lower the blood glucose, and then the exercise is going to kick in and lower the blood glucose. So if they exercise at the same time that the peak is on their insulin, they are at higher risk for having a hypoglycemic attack. So it's really important for you as a nurse, and maybe not for this test, but I'm talking about in real life, it is important for you as a nurse to understand the onsets, the peaks, and the duration, so that you can give your patient good teaching on how to exercise, how and when to exercise, how to plan that maybe if you're going to exercise, then you need to eat an apple before, or eat a snack before to keep that blood sugar from dropping so low that you end up hurting yourself. Then the other thing that you need to know is that when somebody has hypoglycemia, how are you going to deal with that attack? And the deal is that you want to give them carbohydrate and a protein. Okay, you want to give them a simple carbohydrate first, a glass of orange juice, 5 pieces of Lifesaver candy, something that's going to bring their sugar up very quickly. But then you must follow it up with a carbohydrate, a complex carbohydrate, because if you don't, then you're going to have a spike in the sugar and then a trough in the sugar. So you're actually going to cause a rebound effect if you bring up the sugar very quickly, but you don't follow it up with a protein and a complex carb. Because what's going to happen is they're going to have that orange juice and it's going to spike that blood sugar, and then it's going to start to drop it fairly quickly. But if you can come in behind and give them a complex carb and a protein, as that orange juice starts to crash down, that complex carb is there, and it starts to break down too, and it gives them the glucose, and it keeps, instead of having a spike that spirals down, the spike comes and then kind of flattens out more like that instead of a high peak and a high trough. I don't know if that makes any sense, but that's something to think about. And then, of course, you need to make sure that you know the sites for sub-Q injections, because this is insulin, so you know that you can give it in the abdomen, in the thighs, in the back of the arms, and then in the shoulders, and like the back of the shoulders. Those are all sub-Q sites. Okay, and then in your book on page 925, there's a list of oral hypoglycemic agents. You need to be familiar with some of these more common ones, like metformin, like glipizide. You're going to see that a lot. Glyburide, metformin, and then they have metformin and rosiglitazone, which is called Evandamet. You see that a lot. Glipizide and metformin, and that's Metaglip. So those are now coming out, and those are given fairly frequently. I see those two drugs, metformin, Actos, Avandia. I see those pretty often in the setting on my job. All right, so there's a section in here about DKA and HHNK. Make sure that you just read through those two. Make sure that you know about macrovascular complications of diabetes, like atherosclerosis and arteriosclerosis. People who have diabetes often also have hypertension and high triglyceride levels. So it's not just a matter of managing the diabetes or the insulin and glucose levels. It's also managing the hypertension and the triglycerides that come with that. And then, of course, we talked some about the microvascular complications of the kidneys, retinopathy, nephropathy, and neuropathy. And then also gastroparesis. Those are 4 major microvascular complications that you should be familiar with. And then diabetic teaching, what to do when somebody has an infection. An infection is going to cause their blood sugar to be higher. And they really need to make sure that they do very good and very meticulous foot care, because a lot of people with diabetes have neuropathy. They don't know that there's something wrong with their foot until an ulcer develops, and that ulcer is because of the thickness and the microvascular changes that happen with diabetes. It's very hard to heal the wound, and before you know it, people end up having to have amputations, toe amputations, foot amputations, because of poor control of diabetes. So, that very quickly, or as quickly as I could do it and still feel like I did you a half decent job, takes you basically through chapter 10, chapter 40. So I went over chapter 39 and 40 in these two videos. I hope this helps. Good luck on your test. Along with these videos, please make sure that you read the notes, my teaching notes that I gave to my classes in the past. I think that my teaching notes plus these two videos will help you guys. Good luck. Till next time, see you later.